Welcome to the online bariatric surgery informational patient seminar. Over the next few minutes, we'll be able to learn why it's important to treat obesity, as well as medical problems that are associated with obesity. We'll go on to discuss about different types of surgical procedures that are available, and we'll talk about what happens after surgery in regards to medical conditions, risks, and benefits. As far as your surgeon, I am Dr. Jorge Acosta. I'm board certified in general surgery and a fellow of the American College of Surgeons. I'm one of the first fellowship-trained bariatric surgeons in the Southwest and a medical director for Del Sol Medical Center since the year 2004. As a medical director for Del Sol Bariatric Center, we've accomplished many successes and received many awards from multiple medical societies. Currently, we are considered a center of excellence for bariatric surgery, as well as received multiple recognitions from multiple insurance companies. The team that will be involved in your care is truly a multidisciplinary approach. You'll have myself as your surgeon. We also have a program director. We have clinical coordinators, which are registered nurses. We have registered dietitians that are also involved in your care. We also count with insurance liaisons to help you navigate the insurance process as we go along, and as well as psychologic support. Unfortunately, obesity rates continue to rise every year. As of the year 2019, 30% of the world and US population were considered obese. By the year 2030, this rate is estimated to be at 50%. The reason obesity is very important to treat is because, unfortunately, obesity is related or associated with higher mortality rates. And this happens from what's referred to as comorbid conditions. So these are problems that come about because of obesity. And some of those comorbid conditions, you might ask, the three most common are going to be type 2 diabetes, high blood pressure, and sleep apnea, obstructive sleep apnea. On top of that, there's many others, of course. There's lipid disorders like high cholesterol, high triglycerides, issues associated with the liver, in this one referred to as fatty liver, weight-bearing joints becoming worn out. This is referred to as osteoarthritis. So these are the knees, lower back, feet, hips. Another big one that a lot of people don't think about, cancer. Unfortunately, obesity does make patients more prone to certain types of cancer. In females, for example, we see a higher incidence of breast cancer and uterine cancer. In both males and females, there's also a higher propensity of colon and rectal cancer, and on males, in addition to that, increased risk of prostate cancer. In addition to that, we also see psychological problems, things like anxiety, stress, depression, things like discrimination at school, discrimination at work, etc., etc. And then clotting problems with the deep veins of the legs. So obesity does put patients more at risk of developing clots in those veins, which can travel and dislodge and travel to the lungs, and those can be a big problem. There is certain terminology that is important to help determine candidacy for surgery. The term that is used in surgery as well as insurance companies and medicine is referred to as BMI, which stands for body mass index. And body mass index is a calculation that involves a patient's height and a person's weight to give us a number or a degree of obesity. In this chart that you see here, you can see that you can plot your height in feet and inches on the left, and on the top you can plot your weight in pounds, and you see where those two meet, and where they meet, that's going to tell you what your body mass index is. To be a surgical candidate if a patient has a body mass index equal to or greater than 40 without necessarily having any comorbid conditions, this person can be considered a candidate for surgery. In addition to this, if a person has a body mass index between 35 and 40, so a lower degree of obesity, and this person has a comorbid condition such as type 2 diabetes, high blood pressure, or sleep apnea, this person again can also be considered a candidate for surgery as well. There's a third category, which is a lower degree of obesity. This is a BMI between 30 to 35. And if you fall in this category, this is something that insurance companies will not cover. And if that's the case, you have to fund it on your own. In regards to surgical approaches, the traditional approach is referred to as open surgery. And it's basically what it says, where a surgeon will make a large cut and use hands and instruments to do an operation. This was done 15-20 years ago. Of course, the method that I prefer using for all my patients is done minimally invasive. One of the options is laparoscopic surgery, and a laparoscope, what it is a camera. So instead of making a large incision, we employ little incisions, about a centimeter each. One of them gets a camera and do the whole surgery through a TV monitor and do the procedure that way. This has many advantages. You have little small incisions, means a lot less pain. If you have a lot less pain, you're going to be up walking around the same day of the procedure, which means less complications, less clots on your legs, less pulmonary problems, a much faster recovery, which means you get to leave the hospital sooner, back to activities, back to work, back to school a lot quicker. In addition to laparoscopic surgery, there's also robotic surgery that's also available. And robotic is very similar to laparoscopic surgery in that it's minimally invasive. It's the same little incisions, about a centimeter each. The advantages of the robotic platform is that it does provide the surgeon with enhanced precision, as well as enhanced flexibility with the instruments that are used, and better visualization and better optics as well. The first procedure that we talk about is referred to as the Roux-en-Y gastric bypass. For short, we refer to it as gastric bypass. This procedure is done minimally invasive. It's done through a set of, again, small little incisions. They're neither through the laparoscopic or the robotic platforms. With this particular procedure, it helps patients with weight loss by means of restriction as well as malabsorption. During the procedure, what we do is we divide upper portion of the stomach to make a new stomach pouch that's roughly about the size of a boiled egg. This becomes a restrictive component. If a stomach is that size, no longer can a patient eat a large portion of food. Now you eat small amount of food and you get satisfied, you get satiety. In addition to this, during a gastric bypass, we also work down in the small intestine where we divide the small bowel and reconnect it so that the new stomach pouch can drain distally. What this does is that it gives patients about 150 centimeters of intestinal malabsorption. What this translates into is that whatever calories or whatever food you eat, you're unable to absorb all the calories that you consume during that meal. Gastric bypass, as long as the patients follow instructions and they do the right things and they're ready to make changes, gastric bypass has an end result of very good weight loss. On average, a gastric bypass patient will lose between 60 to 80% excess body weight loss. Happens quickly at about a year's time. Patients have reached that goal. Gastric bypass tends to be superior for those patients who have advanced diabetes or difficult to control diabetes. Bypass helps either make it go away completely or make it better controlled. Gastric bypass is also preferred for patients with troublesome gastroesophageal reflux or heartburn. Gastric bypass cures those patients about 95% of the time. One of the conditions that can happen after a gastric bypass is referred to as dumping syndrome. And this can happen after a bypass procedure when a patient eats concentrated sweets, so like dessert, ice cream, those kind of things. When patients eat them, they can get sick. They can get colicky pain, bloated, sweaty, heart racing, diarrhea, etc. So this is a good incentive to avoid those kind of food items. With bypass is very good recovery. Most patients spend 2 nights in the hospital. Generally, within a week, most patients feel pretty good and can return back to more activity after 2 weeks. So it's a very fast recovery. The second procedure that we talk about is referred to as the vertical sleeve gastrectomy. For short, we call it the sleeve. This procedure is also done minimally invasive through a set of small incisions, again, either through the laparoscopic platform or the robotic platform. In this particular procedure, we only work in the stomach. So with this one, there's no work or division being done in the small intestine or reconnecting anything. This work is done purely in the stomach of the patient. And what we do during a sleeve is we divide the upper portion of the stomach to create a significantly reduced capacity stomach. Different than a bypass, the excluded portion of stomach that's stapled off, that one is extracted, is removed. So the patient ends up with a stomach that's shaped like a sleeve on a jacket. Some people call it a banana because it's shaped kind of like a banana. But in essence, we go from a volume, gastric volume that initially was 1.5 liters. We shrink that down to about 80 milliliters. Okay, so this is a purely restricted procedure. If a patient has the surgery, eat a small amount portion of food, and the patient satisfied, they're full. In addition to being restrictive, a gastric sleeve also induces changes in the gastric hormones because a portion of stomach is removed. This reduces hunger hormones that are secreted by the stomach. The end result is that a good majority of patients after a sleeve will report that they are no longer hungry. They eat because it's time to eat, but not because of hunger. Because of all this, patients that have a sleeve also are very successful in regards to weight loss, as long as they're, again, ready to make changes and ready to follow instructions. On average, sleeve patients will lose about 60 to 70% of their excess body weight loss, and this happens quickly. Within a year to 18 months, most sleeve patients have already reached that goal. Because it's minimally invasive, this is again fast recovery, 1 night in the hospital, and by the time a week goes by, most patients feel pretty good and back to full activities and normal activity within 2 weeks. In regards to surgical risks, this is very similar to most surgical procedures. Specific to sleeve and bypass, one of the risks patients need to be aware of is referred to as a leak. So if where we divide the stomach or where we connect stomach to small bowel, if that's not 100% watertight, can result in a gastrointestinal leak. And if it occurs, generally means reoperation to address. My personal leak rate is very low. Last time I had to address an anastomotic leak was in the year 2012. But patients need to be aware that it's a potential risk. We test for leaks during surgery and after surgery with an X-ray to make sure that we're not dealing with any of this while the patient's still in the hospital. Next risk that we talk about is referred to as a deep vein thrombus. This is a clot that can occur in the deep veins of the legs, and if they dislodge, they can be a big problem because they lodges the circulation of the lungs. We take precautions for this as well. Everybody has squeezing devices on their legs. We give patients blood thinners before surgery, continue those after surgery, usually until patients go home. Some patients that are deemed high risk, we may continue that for a couple more weeks. So DVT rate is extremely low as well. The next complication that's mentioned here is the stricture. This is a narrowing. Could be at the staple line or at the connection between the stomach and the small bowel. If a patient gets one of those, usually requires dilation by means of an endoscopic balloon. This is extremely rare. With the technique that I use with a gastric bypass and a sleeve, I honestly can't recall the last time one of these occurred, but it's a rare occurrence. Then there's the risk of a hernia. Could be a hernia from any one of those little incisions. Could also be an internal hernia. I can tell you personally, internal hernia rate is extremely low, and that's because during surgery, any potential hernia space that is encountered or that is produced during surgery, all those are closed at the time of the procedure. The next risk that's mentioned is an ulcer. And ulcers can occur, especially the two biggest risk factors. One is smoking, cigarette smoking. So this needs to be avoided. And certain medicines, such as medicines in the family of aspirin, so if a patient uses this for pain control, we may have to switch to a different pain control family to avoid ulcer. And ultimately, risk of death. And I can tell you, with the current approaches and the current care techniques, death rate from bariatric surgery is extremely low. This falls at about 2%. Falls at about the 0.2%, which is the same rate as that of common surgery, such as gallbladder surgery. It is very important for patients to realize that bariatric surgery does require lifelong follow-up. After surgery, patients are seen at 2 weeks, at 3 months, 6 months, 12 months, 18 months, and annually thereafter. This is something that does require us to be monitoring patients with frequency. This is a whole multidisciplinary approach on every visit. Patients seen by myself as your surgeon, they're seen by a registered nurse, they're seen by a dietitian, and this is very important to help patients accomplish their targets and targets in projected weight loss as well. During certain intervals, we expect a certain amount of weight loss, and if the patients are doing great, that's awesome. If not, so that we can work with the patient to have them achieve a better success. During certain visits at certain intervals, we also need to start checking for nutritional, vitamin, and mineral parameters. Every patient that goes into surgery, you're gonna have to supplement for the rest of their lives. Okay, you're gonna have to be supplementing a multivitamin, vitamin B12, calcium, very often vitamin D, sometimes iron, as well as protein supplementation, and this is forever. No matter what procedure, you will have to supplement. So all this becomes very important that we keep in touch with these patients and keep following them up as time goes on to make sure that they're doing well over time. Ultimately, the reason we do these procedures is to help patients improve or resolve their more comorbid conditions or medical problems. And after surgery, we see very good success in making some of those medical conditions go away or improve. For example, with obstructive sleep apnea, we see about a 90% resolution of sleep apnea. For problems like hypertension or high blood pressure, 70% resolution where patients no longer have to take pills to control their blood pressure. For type 2 diabetes, we see between 80 to 90% remission of diabetes, where patients don't have to take pills, don't have to use insulin. Basically, blood sugar normalizes, as well as hemoglobin A1C. And as you see on the list, there's many other medical conditions that improve significantly after a successful weight loss with bariatric surgery. And ultimately, as you see on the bottom of the list, quality of life is improved in about 95% of the patients. What this means is that patients are now able to do things that before maybe they couldn't do, whether it be able to walk more or being able to exercise, being able to travel more, being able to get on a roller coaster or chase after your grandchildren, whatever it is that brings you pleasure, that patients are able to do those things. Some key points that I'd like to make before we're done. First one is that certain criteria have to be met to have surgery. There's of course the BMI or body mass index criteria. There's also criteria set by individual insurance companies where they require patients to be on a weight management program before surgery. Criteria set by me as a surgeon, make sure you're a suitable surgical candidate. There's criteria set by a dietitian. Also criteria set by a psychologist. This is something that's required by most insurance carriers, so we do have to fulfill those before we can actually have surgery. This is major abdominal surgery, even though when patients wake up, all they see is little small incisions and maybe not too much pain, but what we do inside is a major operation, and that's how it should be thought of. Very important for, especially obviously on females, you have to avoid pregnancy for at least a year and a half after surgery. And that's the time that patients are losing weight rapidly, so obviously we don't want rapid weight loss to interfere with a developing fetus. So you have to take special precautions to avoid pregnancy for at least a year and a half. Very important too, this is not the easy way out. Okay, a lot of people say, oh, you did surgery, so you took the easy way out. By far it isn't. It requires a lot of work. requires a lot of devotion, and it requires a patient to be ready to start making changes and follow instructions. If the patient is willing to take that step, we're going to have excellent outcomes, and a lot of these problems will go away related to obesity. And lastly, I encourage you to get know your surgeon. I am fellowship trained in these kind of procedures. I have thousands of procedures under my belt, and besides the number of procedures that I'm able to keep complication rate at the very minimum, if not less than what's seen on national averages. And those are the numbers that I'd like to look at. Congratulations! You just finished the very first step in your bariatric surgery journey. I would love to be involved in your care and follow you in this transformation to a much healthier individual. So don't wait. Call 915-250-0220 during regular business hours to schedule your first appointment.